Welcome to the debate. Our discussion today centers on, well, perhaps the most enduring and complex policy challenge facing any modern democracy: how to design a national healthcare system. We're talking about balancing coverage, costs, choice, and the necessary regulations. The material we're drawing from really highlights the deep disagreements here.
Indeed. I mean, we aren't simply quibbling over, marginal tax rates or something. We're examining two fundamentally different philosophies regarding healthcare delivery and, frankly, its role in society.
Absolutely. And that brings us straight to the central question we need to grapple with today. Should the primary mechanism for achieving affordable and universal healthcare be fostering competition, consumer choice, market incentives, or should that goal be achieved through public rules, centralized standards, and secure funding that's explicitly designed to treat healthcare as a social good? I'll be arguing today that the most efficient and ultimately consumer-friendly path is that market-centric approach.
And I come at it from a different way. I'm going to argue that public rules and guaranteed universal access are just indispensable because health security isn't a commodity, right? Relying on market forces alone, I believe, guarantees instability, debt, and serious gaps in essential care.
Okay, so my central argument is, I think, pretty straightforward. Markets innovate. They reduce costs most effectively when consumers are empowered with real choices and, crucially, clear price signals. Therefore, the government's role should be surgical and targeted. A robust safety net for the vulnerable? Certainly, yes, but not the default payer for the entire population. To really bend the cost curve, we have to lean heavily on competition. That means encouraging a wider variety of private plans, maybe enabling interstate insurance sales to increase that competitive pressure, and critically, using tools like health savings accounts, HSAs, which let patients save pre-tax money and control routine spending. We absolutely need price transparency so patients can actively shop for care, turning passive users into active consumers. Now, when you pair that consumer empowerment with supply-side reforms, things like easing regulatory burdens on facilities, reforming scope of practice laws to let, say, nurse practitioners practice fully without physician oversight, you create genuine efficiency. And I'd point to Medicare Part D, back from 2006, as some powerful evidence. By setting up a system that provided substantial subsidies, yes, but required competition among private insurers to manage formularies and benefits, well, the program's costs grew slower than the initial forecasts predicted for years. That's market competition delivering results even within a public program framework.
That's a compelling case you make for markets, but I just don't buy that those principles can solve a problem that's really defined by information asymmetry, inelastic demand, and frankly, the moral imperative of sickness. If you fracture the risk pool through all this voluntary choice, you guarantee instability. Healthcare, especially when you're seriously ill, it's just not shoppable. It is, I believe, unequivocally a social good, and relying solely on private markets will inevitably fail to guarantee universal, affordable coverage. That leads to delayed care, medical debt, personal catastrophe. You know the stories. Our focus must be on achieving universal or at least near universal coverage, and that requires public rules and funding mechanisms. We need to protect and, I'd argue, expand the Affordable Care Act's architecture. Primarily, that means establishing cost controls via public standards. Things like essential health benefits. Community rating, meaning everyone in an area pays the same premium regardless of health status. And robust caps on out-of-pocket costs. Look at the ACA exchanges, the subsidies, the Medicaid expansion since 2010. They've been tremendously effective in dramatically increasing the coverage rate, reducing uncompensated care. And furthermore, we're now seeing targeted reforms like the gradual phasing in of that $2,000 annual out-of-pocket cap for prescription drugs in Medicare. That's public standards driving affordability and risk protection directly.
Okay, I see why you emphasize those comprehensive public standards, particularly for risk management. But let me offer a different perspective on cost control. You focus on the government leveraging its, immense buying power. Whereas I argue we need to empower millions of consumers to collectively restrain prices. So look, if we strengthen consumer incentives, maybe by promoting catastrophic plans, especially for the young and healthy population who often delay getting insurance, and you couple that with mandated price transparency rules, well, Then you empower individuals to actually say no to excessive costs. Price visibility, like standardized posted rates for hospitals and labs, allows patients to behave rationally when they're seeking what we call shoppable services. MRIs, routine labs, maybe elective physical therapy. We have to acknowledge that the majority of healthcare spending, something like 80%, is spent on chronic and routine care, therefore shoppable services, not just sudden emergencies. If we can restrain those prices through competition, we create system-wide savings. And let's be pragmatic about efficiency. We absolutely need site-neutral payments. That's a crucial policy fix. Why should we pay dramatically different amounts for the exact same service, say, a chemo infusion, just because it's given in a high-cost hospital outpatient department versus an independent clinic? Paying the same rate promotes competition and restrains that price inflation driven by facility fees.
That's an interesting point regarding price transparency, and I do agree site neutrality is necessary. But have you really considered the real-world limits of shopping for care? Even for routine services, the patient often lacks the necessary information to compare quality. And let's be honest, when your doctor advises you to get an MRI, how many consumers are really going to challenge that referral based purely on price? The efficacy of market shopping is highly limited, I think, in a system where price absolutely does not equal quality, and the provider holds pretty much all the informational power. If we want to truly bend the cost curve, we have to use policy interventions that reward value, not just volume.
This means leveraging the government's massive scale through mechanisms like Medicare payment reforms, things like bundled payments, which pay one lump sum for an entire episode of care, or hospital readmission penalties, which incentivize better post-discharge coordination. Those are public standards that force efficiency in ways consumer choice simply cannot. And, most critically, expanding the government's ability to negotiate drug prices is probably the single fastest way to achieve major cost savings.
They do come with a significant vulnerability: access. Centralized government programs, when they attempt to control costs primarily by setting provider rates, frankly, too low, they risk creating real access issues. We're talking narrow provider networks, long wait times, and potentially a general provider flight from public plans. We see concerns about this already in certain states that aggressively limit Medicaid payments. If the payment rate is too constrained, the care becomes inaccessible, and that renders the coverage sort of meaningless, doesn't it?
And the vulnerability of your market-driven approach is, I think, glaringly clear. It creates what we call adverse selection and rampant underinsurance. Adverse selection happens because when you rely on voluntary enrollment, only the sickest people tend to buy the comprehensive plans, leaving these skewed, expensive risk pools. So to counter this, plans lower their premiums by hiking deductibles way up, resulting in underinsurance. Consumers, trying to secure those appealingly low monthly premiums, often opt for plans with extremely high deductibles, sometimes $7,000 or more, and limited benefits. These plans are effectively useless when a major medical event actually occurs, which just forces consumers into debt. And the short-term and association plans you seem to favor often exclude essential benefits or, crucially, pre-existing conditions coverage. That means the policy provides no real security at all.
Or lack thereof of some high-deductible plans. But I think we can manage that risk without resorting to full public control. To address risk protection specifically, I'd argue for flexibility paired with a genuinely targeted safety net. I defend the concept of using block grants or perhaps per capita caps for Medicaid funding to the states. This gives states the flexibility to innovate, to design programs that best fit their unique populations, rather than forcing a federal sort of one-size-fits-all model. And you pair that state flexibility with robust targeted reinsurance or high-risk pools specifically designed to absorb the cost of the most expensive patients. State waivers, particularly the flexibility offered under Sections 1115 and 1332, they've already shown success in stabilizing individual markets and, in several cases, demonstrably cutting premiums by managing risk effectively at the state level.
Reasoning, because block granting Medicaid, it feels like giving states an umbrella that vanishes the moment it starts raining. It inherently risks cutting coverage and benefits during economic recessions or, say, high-cost public health years, precisely when people are losing their jobs and need those services the most.
The entire purpose of a federal standard is to prevent those kinds of arbitrary cuts. We really must acknowledge that the core strength of this social good approach, the fundamental advantage we hold, I believe, is robust coverage and risk protection achieved through universal, non-negotiable rules, mandating coverage for pre-existing conditions and providing necessary premium subsidies. That makes insurance meaningful. It dramatically reduces the financial stress that is currently driving so much household medical debt. Your targeted safety net, I fear, leaves far too many individuals falling through the gaps, resulting in what are really illusory choices if those private market networks remain thin and restrictive.
Okay, we have established some genuine friction here regarding the efficacy of consumer-driven versus policy-driven cost control. But I think the material also services some tremendously important bridging ideas we should recognize and, frankly, pursue immediately.
Absolutely. Despite the fundamental philosophical clash, there are clear areas of policy overlap that really should already be implemented. Reinsurance and risk adjustment, for instance, they are proven policy victories. Reinsurance stabilizes the individual insurance markets by protecting insurers against those really big outlier claims, making premiums more predictable. Risk adjustment ensures that insurers who take on sicker populations are compensated fairly, preventing that adverse selection problem we talked about. We see broad, bipartisan support for these mechanisms, and they are essential for universal access, really regardless of whether the system ultimately leans more public or private.
That's a good point, though I might frame their importance a bit differently, focusing maybe more on supply-side solutions as the most efficient bridging ideas. If we genuinely want to reduce costs quickly, we have to increase the supply of providers to meet demand. That naturally restrains prices. This means not only expanding residency slots, but speeding up the credentialing process for new providers, boosting nurse practitioner autonomy where it's safe to do so, and rapidly speeding up facility approvals by revising or eliminating those often antiquated certificate of need rules that, let's be honest, often protect existing hospital monopolies rather than promoting new competition. These are inherently efficiency-driven ideas, which points back to the core strength of the market-centric view: incentives plus supply. If supply increases, prices tend to drop, and access improves for everyone.
And on the cost side, yes, we must both acknowledge the shared interest in site-neutral payments. Though, as you hinted, our rationales for endorsing it remain distinct, which I think is quite telling.
Precisely. I see site-neutral payments as the immediate way to enforce genuine market competition and efficiency by eliminating that arbitrary facility fee gaming, essentially forcing hospital systems to compete on price for services that can clearly be provided safely in a lower-cost setting.
While I see it as a necessary public standard for cost control, one that prevents hospital systems from leveraging their massive market power to charge excessive outlier facility fees, which just drains resources from patients and payers alike. For me, it's cost containment through regulation.
So, our debate today clearly illustrates that the market approach, emphasizing, powerful consumer tools like HSAs and significant supply-side innovation, whether that means expanding telemedicine or increasing provider capacity, it certainly can reduce certain costs quickly and drive efficiency. However, I must acknowledge the vulnerability inherent in this approach. If it's not regulated correctly, it does risk fracturing the risk pool, and that can yield rampant underinsurance and significant gaps in care, especially for high-need patients who might be reliant on thin private market networks.
And I would just reiterate that health security must be seen as a prerequisite for both social and economic opportunity. I remain confident that policy interventions can reliably bend the cost curve through targeted reforms like drug negotiation, payment reform, and establishing guaranteed access for all. Now, while the public standards approach prioritizes that guaranteed security, I absolutely acknowledge the significant implementation risk that comes with massive government action, the complexity, the bureaucracy involved in procurement, and yes, the unavoidable political trade-offs concerning the taxes or premiums required to fund a truly comprehensive, universal system.
What this persistent complexity ultimately shows us, I think, is that the ongoing political division is often amplified by, metric cherry picking. One side consistently focuses only on premium increases as proof of failure. The other side points only to uninsured rate drops as proof of success. Both sides are often using different baselines to claim victory.
Which is exactly why it's so vital to judge any plan by a comprehensive set of success metrics. We have to look at the uninsured rates, certainly, but also critically assess underinsurance, the share of the population facing over, say, 10% of their income in out-of-pocket costs, and those crucial metrics of financial stress, things like medical debt mentions and bankruptcy rates, clearly linked to healthcare costs.
Absolutely. The material really demands that we seriously and respectfully consider the merits of both targeted market incentives and robust public standards to fully address the intricate challenge of healthcare finance and delivery in this country.